Bjorn?
My apologies to Peter. Did he leave? Because I'm going to take the opposite tact here. I didn't know this was a debate. I didn't prepare it that way, but I guess it may be. In any event, I certainly agree with the assigned title and think that that's the best way to do EVAR. These are my disclosures. We know that EVAR has significant advantages over open surgical repair, mostly with early morbidity and mortality. For at least up to 4 years. There are increased reinterventions with EVAR compared to open surgical repair. And if you look at late all-cause mortality, there's really no difference. And there is, again, a higher rate of reintervention with EVAR, it seems. The issue with EVAR here, looking at data from the DREAM trial published a number of years ago in the New England Journal, is the late durability issue. So as you see here at 4 to 5 years out, you start seeing those lines diverge in terms of freedom from reintervention, suggesting that long-term durability of EVAR may not be as good, and that some of these patients may be subject to late failures. There's similar data from the United States. This is Schemmerhorn's paper looking at outcomes of EVAR and open aneurysm repair in the U.S. Medicare population for an 8-year period of time with up to 8 years of follow-up. And a few things to take from this study. First of all, it does confirm that EVAR is safer than open repair in terms of short-term outcomes, with a threefold relative risk reduction for mortality across all age brackets. EVAR patients are more likely to be discharged home rather than the SNF compared with open repair. If you look at survival, there's an early survival advantage from EVAR, but again, that's lost over time, but still equal to open surgical repair in terms of overall survival at 8 years. In terms of reinterventions and complications, EVAR did have a higher incidence of late aortic rupture. EVAR had a higher incidence of aneurysm-related reinterventions than open surgical repair. Open surgical repair does have an increased incidence of laparotomy-related reinterventions like bowel obstruction and hernias, as you might imagine. But overall, EVAR still had a higher rate of reintervention than with open repair and long-term follow-up. So here's the problem and the patient that we don't want to come back, maybe one we did off of IFU, but this is a patient that I recently saw in my office. I didn't do the original repair, but here you see a large proximal type 1A endoleak. This patient has problems distally too with bilateral type 1B endoleak. So basically the graft's just floating in there and the contrast and blood is just traveling right around that graft, and I don't think it's providing any protection from aneurysm rupture. So why does EVAR fail in patients? Well, we can kind of break it down. You can have device failure with fabric tears or stent fractures and durability issues of the devices themselves. You can have aortic failure where there's progressive neck dilation or disease progression with progressive aneurysmal dilatation of other non-treated segments. Or it could be physician failure where you're doing cases off IFU, where maybe you're not so good at your case selection or your device selection for specific anatomies and patients. I think by and large, device failure is not such an issue anymore. We're on to 3rd and 4th generation devices. We're not seeing fabric tears and stent fractures and that kind of thing. And most of what we're seeing now in patients who live long enough is aortic failure or physician failure that we just used bad judgment and didn't apply the technology right. This paper was already cited, the Schanzer paper, showing that in the U.S. in this analysis of over 10,000 patients that less than 50% met IFU criteria. 41% of patients in the follow-up had continued and progressive sac enlargement of more than half a centimeter, and that was associated with large or short proximal necks and common iliac artery aneurysms and short distal landing zones, so basically patients done off of IFU. This is a Cleveland Clinic experience looking in specifically at patients who had failure of EVAR, who they then went on to treat with fenestrated and branch grafts. Almost all were proximal neck failures due to either migration or a type 1A endoleak. And they found that factors associated with failure after EVAR were younger patients, so maybe a genetic predisposition towards progressive aneurysmal disease, and large proximal neck diameter and short neck length. This is the Albany experience where they analyzed over 3,000 patients that had been treated at their center and in the region. They treated 45 patients with delayed ruptures after EVAR. All of those patients had a proximal type 1A endoleak that was responsible for the rupture. Over 60% had been treated outside of IFU. And the patients more often who had presented with those ruptures more often had larger neck diameters, 28 millimeters versus 24 millimeters, shorter necks, 12 millimeters versus 22 millimeters. This is going back and analyzing their original CT scans, and higher degrees of neck angulation, or what you may call hostile neck, or necks that were off IFU. Now we've got a host of devices that come in sizes up to 36 millimeters in diameter so that we can treat neck diameters up to 32 millimeters in diameter. But I think over time, is that a normal neck? What's going to happen? These are on IFU now with large proximal necks, but are the ultimate outcomes, if the patient lives long enough, still going to be the same as patients who don't have these wide necks? It's not clear. This is one publication just published in JVS, looking at a European experience with over 400 patients treated with the Endurant device. 74 of those patients had neck diameters in excess of 30 millimeters. They compared that versus a matched controlled population of 353 patients with neck diameters less than 30 millimeters, with good median follow-up in excess of 3 years. And basically what they found was there were significant differences in these populations. So in those patients with the large or the wide necks of 30 millimeters or more, there was lower freedom from neck-related adverse events, and if you looked at primary clinical success, it was significantly worse, and that was a composite endpoint looking at freedom from endoleaks, ruptures, and aneurysm-related reinterventions. The same is true distally. It's just easier to handle. We have all these flared iliac limbs. We can treat now iliac diameters up to 25 millimeters in diameter. Again, is a 25 millimeter diameter a normal distal landing zone, or is that actually an aneurysm? Well, if you do use these flared limbs within IFU guidelines, the good news is that most of those patients do fine, and there's really no difference in rates of type 1 endoleak or iliac-related events, sac enlargement, or reinterventions if you stay within the IFU guidelines. But the reality is that a lot of us are using bell-bottom techniques and things where we're doing things outside of IFU, and then there is a higher incidence of complications like distal type 1B endoleaks, retrograde migrations, and component separations. This was one paper that was presented at VAM, again comparing patients with iliac issues either on or outside of IFU, showing a significant increase in iliac issues in those patients who were outside of IFU. So, we know that we have techniques now with both branch grafts and coil and cover techniques. I personally think we should preserve hypogastric arteries when we can, but certainly we can go to more normal distal landing zones as well, and I think that that's probably appropriate. I'm going to show a few cases and some patients that we've treated with some different techniques to rescue failed or failing EVARs. This is a patient, unfortunately, we couldn't rescue, who 1 year earlier, probably for a very wide and probably short-necked aneurysm, had a EVAR with a 36 millimeter diameter device that had a type 1 endoleak at the end of the case. That was treated with endo anchors, apparently with a good result, but came back 1 year ruptured and actually died from this rupture. People have proposed that maybe novel technologies with sealing techniques with like the EVAR grafts, that maybe you don't need a neck. Well, I think that the lesson learned with that is that you probably do. You still need to get some proximal normal aorta or near normal aorta for fixation, and this is a recent publication looking at outcomes with EVAR in patients with short neck or juxtarenal aneurysms, and here you can see with follow-up the separation of those EVAR stents and endobags and the development of an endoleak, and in necks less than 4 millimeters in length was associated with a need for open conversion in this experience. So that's where some of these techniques with more complex EVAR, where we can go more proximally to get good proximal landing zones. This is a zenith fenestrated device, which most people are familiar with. Here we can extend proximally, incorporating visceral arteries to get good length of parallel aorta for proximal fixation. Here's a case that I did a number of years ago showing in follow-up progressive decrease in size of the aortic aneurysm and stability over a number of years. And by and large, that's been the results that have been reported, where if you look here with up to 5 years of follow-up, a very low incidence, even in these complex juxta and pararenal aneurysms, of 1% or less by and large. We know with fenestrated techniques we can increase the neck length. So here's a juxtarenal aneurysm, and now by moving the graft proximally through that visceral segment, we're getting nearly 3 centimeters of proximal neck coverage with parallel aorta by using a fenestrated technique. Don't have to use fenestrated devices. There are other techniques. This is a chimney technique where we used with an ovation device to move the proximal sealing zone proximally in a patient who was not a candidate for open repair. For more complex aneurysms, certainly there are evolving branched and fenestrated technologies. Currently, they're not commercially available in the United States, but they are outside of the United States. We're fortunate to have access to some of these devices. So this is a late failure after EVAR with a proximal type 1A endoleak. Probably this patient was never on IFU. You can see basically the start of the aneurysm right below the renals with a short proximal neck. And this is one that we converted with a customized proximal fenestrated cuff to resolve that endoleak. But it's not just short-necked aneurysms and dilation of the neck. This is a patient who had progressive proximal dilation of the aorta and basically a thoracoabdominal aneurysm now proximal to the device. The device hasn't failed. There's no leak here, but now you have a large aneurysm almost 10 centimeters in diameter proximal to that device. And another example here of a patient who probably all along had a thoracoabdominal aneurysm, maybe had a little waist around the level of the renals. If that patient lives long enough, this will dilate and they'll form an actual thoracoabdominal with failure ultimately of their EVAR device. This patient has a type 1A endoleak as a result. And this is one that we would correct basically by doing a total reconstruction of that visceral segment here, in this case with a branched endograft that we ordered. So, beware of the posterior bulge. This is a patient that looks pretty good, maybe juxtarenal, maybe we'll do a Z-fin here, maybe it's a good commercial Z-fin case, but look in the lateral projection here. This entire posterior aorta throughout the visceral segment, even up to the supraceliac aorta, is not normal. This is not a good proximal landing zone. This will ultimately fail. And in this case, we actually chose to go to normal proximal landing zone with a branched endograft technique. So to wrap up here, late failure after EVAR is most commonly due to physician failure and progression of aortic disease. Landing in normal aorta proximally and distally improves patient outcome, so I wouldn't be an advocate of pushing the limits in terms of IFU necessarily. Patients treated outside of IFU or at the fringes of IFU may need more aggressive surveillance to make sure if they live long enough that they don't develop EVAR failures, and fenestrated and branched stent graft techniques offer the ability to treat patients with complex aneurysms still landing in normal aorta and iliacs. Thank you.